So, hello, Tila. Welcome to The Nutshell. First of all, where did it all start for you? You are a plant-based GP, a lifestyle medicine physician, a health coach, and you're also what's called a gypsy or a GP specialist in chronic fatigue syndrome. So, how's this all come about?
I was born into an Indian family who are Hindu. So we have this concept of ahimsa. We know about the benefits of vegetarianism in terms of the ethics of vegetarianism. So I was brought up as an omnivore, but I only ate meat outside of the house. And then I kept flitting back and forth between being vegetarian and an omnivore. 7 years ago, and I just had my two kids. I had like some health problems as well, and I just came across this advert for Cancer Research UK called Veg Pledge, talking about a challenge to go vegan. And I was already thinking about doing it. Several members of my family had turned vegan or vegetarian, and they'd basically sparked some sort of curiosity. I always felt guilty about, eating meat. So then I thought, you know what, let me do this. And then I spoke to my husband, who was like a very avid sort of omnivore. And I said, will you be okay with me doing this? And he goes, actually, I've been feeling guilty about eating meat as well, because meat tends to go off and, an animal has died for you. So let's do this challenge. If I want to eat meat, I'll eat it outside, but we're all on board. So I did the pledge for a couple of months, and I had tried to lose weight on just a calorie restricted diet, just a generic one. I'd done keto as well. But then I was just so surprised at how easily I lost weight and how I felt better. And I challenged myself at the same time. I had no nutritional knowledge at all. I had no idea, even though this was a cancer research pledge, of the benefits to health and how that correlated. But I just thought, you know what, I'm going to challenge myself to eat mostly whole foods and not lots of kind of meat replacements, although they do have their place. And I was, astounded by the benefits. But I only really learned about the health benefits during COVID, and I became quite passionate about it. And then my mum got a precancerous lesion in her lung, and she was living separately to me. She was advised by Macmillan that, just eat and drink whatever you want, right? You need the calories. So she'd gained lots of weight. She got kind of like this misinformation about not exercising as well and resting completely. And I hadn't seen her for months. And then we got COVID. And I just thought we'd come out of having COVID. This is the best time for her to come and stay with us. And she came and stayed with me for a couple of months. And before, she was kind of like laughing and joking and just saying, you know what, I think you're being too extreme. You need to be a bit more flexible with this way of eating. But then when she saw it's actually quite simple, you're just making a side salad that you're having with normal sort of Indian food, she goes, I want to do this as well. I also started exercising with her. So we'd walk to the park, and she'd pace her activities because, she was breathless at the start. But then she could kind of walk uphill without needing to rest, not needing to take a car and park closer to the park. So gradually and surely she got better, and I learned about the health benefits as well. Back then, I was working for this service called Hospital at Home, which helps people that are at risk of being in hospital, treated with, IV antibiotics and things like that. And that's for Hertfordshire Community Trust. And my manager just came around saying, is anyone interested in this job for the chronic fatigue syndrome service? Back then, I didn't really know much about CFS or ME. My colleague was just sitting opposite me, and she knew that I was interested in lifestyle medicine. And I hadn't done the diploma in lifestyle medicine, but I'd done a nutrition course with Winchester University, headed by Dr Shireen Kazam. And my colleague just heard me say no to the manager, and she said, do you realize that it's self-guided management within this service? So I think it would really, really suit your skills. So I applied for the job, and she got her colleague as well, who's also interested in lifestyle medicine. We both ended up doing the BSLM and IBLM together. That's how I got into sort of lifestyle medicine.
Fantastic. I mean, just hearing about the advice that your mum got at that time from a cancer organisation about not exercising and things, and anyone who's even touched on lifestyle medicine, that's quite shocking to hear, isn't it? We're going to talk to you, aren't we, about chronic fatigue syndrome specifically. If we take a step back and go back to basics and just ask you, what exactly is chronic fatigue syndrome? And there's another term which I'm not sure if it's the same thing exactly, but we've got this myalgic encephalomyelitis, or the ME. Are they the same?
Yes, the terms are used interchangeably. Myalgic encephalomyelitis is the term that was initially used, and now we interchangeably use ME, so that's the abbreviation for it, slash CFS or chronic fatigue syndrome. And it's a syndrome, so it's a constellation of symptoms that patients share. There's a triad of symptoms that you have to have, and the most important being post exertional malaise. So every time you do a physical activity, you are tied out of kilter of the activity. It might be, something like doing the chores at home, hoovering, and then you have to take 2 or 3 days to rest. Malaise, that's fatigue, it might be delayed. So it might not be that straight away you're tired. It might be that you notice it the next day, for example. And it can be very, very disabling. Then you've got brain fog and unrefreshing sleep. So it doesn't matter how long you sleep for, that sleep doesn't feel refreshed. And there's lots of other sort of symptoms that are related. So you can have POTS every time you get up from sitting or lying down, your heart rate goes up. You may have palpitations and feel dizzy, for example, and feel like you're going to fall. You can have temperature hypersensitivity or tender glands in your neck, for example, all manner of symptoms. And you can have gut disorder as well. So it's a multi system disease. We don't know quite what the cause of it is. It was thought to be due to a virus. So it's been recorded as a syndrome as far back as the 1930s. And in the 1950s, the term benign myalgic encephalomyelitis was used. The reason being, they used the term benign ahead of it because it wasn't a condition that caused mortality, and there aren't any lasting structural effects. It's not like Parkinson's disease or multiple sclerosis. There have been more studies done, and there were some psychiatrists in the UK actually, after an outbreak at the Royal Free Hospital in the 1950s, who studied patients with ME/CFS. They kind of stigmatized the condition, and they came to the conclusion that it was a neuropsychiatric condition because it mostly affected women. And they thought that it should actually be renamed as, something like mass hysteria, basically, and because of the lack of, any biochemical markers of the condition. However, that term benign was dropped because it was felt, after following up patients with ME/CFS, that it's a very disabling condition. It's no joke. So the term benign was dropped, and it was just classed as myalgic encephalomyelitis. But then in the 1980s, there was another outbreak in another London hospital. The CDC was reviewing the terms used, and they classified the condition as chronic fatigue syndrome because they thought it was more of an inclusive and neutral term, because myalgic encephalomyelitis sounds a bit scary. It sounds like it's inflammation of the brain, and we don't know what actually causes the condition. With every condition, it's very difficult to name them accurately. Right. So it has been criticized. I mean, the term chronic fatigue syndrome has been criticized because it's seen as trivializing the condition just as a fatigue syndrome, but actually it can be very, very serious. Some patients are bedbound, for example, and can't leave the house. So it's quite difficult to get the terms right. So those terms are used interchangeably. There are patient groups that believe that the term ME should be reserved for very severe forms of the syndrome. But in any case, the management is very similar, and we focus on self-management techniques.
Sort of listening to that, any of those symptoms could present to a GP in a consultation, that somebody is tired when they exert themselves, and you're thinking as the GP, could this be cancer? Brain fog is obviously very common in menopause, and lots of people come in complaining of not feeling refreshed when they sleep. So when should we be suspecting that all these things add up to chronic fatigue? Is there a time limit that we should be seeing there, that it's after 6 weeks or 3 months or longer?
So there is evidence that intervening earlier is helpful. And I think, it's helpful to actually look at anybody that presents with fatigue symptoms that are, disabling, regardless of how long they've been for. We can intervene early, and sometimes, we don't need to then refer a patient to a specialist centre because they may get better. So there's always a chance to intervene early. But the NICE definition, so the guidelines say that the fatigue must be present for longer than 6 weeks. But by the time most patients actually present to a doctor, it's usually 6 weeks anyway. And it's a diagnosis of exclusion. There's no evidence for any blood tests or scans that can diagnose the condition. So we need to make sure the fatigue is not due to other conditions that can potentially be reversed or treated. For example, if someone's got uncontrolled diabetes, we commonly look for thyroid disorders. Hypo and hyperthyroidism both can cause fatigue in different ways. Then you've got, things like adrenal insufficiency, celiac disease. So lots of conditions have fatigue as a symptom. So it's really important to rule those out or make sure that they are controlled in the best way possible.
One of the things you said in the run up to this was we don't know what causes it. And actually that was one of our questions. Do we know anything? Are there any hypotheses about what might cause chronic fatigue?
It's thought to be due to a viral trigger. So there seems to be some sort of inflammation that is building up from before, but then there's some sort of viral trigger or emotional trigger that sets off the symptoms. Now, it's been postulated that it's due to EBV. We haven't proven that yet, but there was a recent study done. And bearing in mind, it's quite a small study, there were only about 17 patients that met the criteria for a diagnosis of chronic fatigue syndrome. But this study was published in Nature quite recently, I think last year or early this year. They did some deep phenotyping to look at what do patients with chronic fatigue syndrome have in common compared to members of the general population without chronic fatigue syndrome or ME. And they found that there's a complex etiology. We can prove correlation because it's a snapshot, right? But we can't prove causation. But the correlations were there was a difference in the fecal microbiota of ME/CFS patients compared to controls. There was also some inflammation going on. So there were T cell lymphocytes or B cell lymphocytes that were higher in patients with ME/CFS in the CSF fluid. So that's in the spinal fluid. And also there was a mismatch in terms of energy regulation, in terms of what the brain perceived the body could do and what the body could actually do. So, they saw that what these 17 patients had in common is that the parieto-temporal region of the brain was sort of misfiring. The good news is from these studies, like I've mentioned before, there wasn't any irreversible damage to the brain or any other system. So that gives us hope and positivity that actually, it potentially is a condition that we could treat or make better. And actually, it is a small study, but, more studies need to be done to look into that condition. And I mentioned that, ME/CFS has been stigmatized and therefore there aren't many studies done on the condition. What's really helped is that long COVID presents in a very similar way and now can be classed as ME/CFS if patients have persistent symptoms. And so, there's more studies going into that and more awareness about ME/CFS because of long COVID. It's unfortunate, but fortunate that we're moving forward with this. So hopefully we'll get some more answers about what the etiology is. There is some link between PTSD and ME/CFS. So there was another study done, again, quite a small study, 78 people with ME/CFS compared to the general population. People with ME/CFS had a higher prevalence of PTSD or traumatic events that have occurred in their life. They had more kind of psychological factors, but it's really, really important to understand that this is not just anxiety and depression. So yes, you get more symptoms of anxiety and depression amongst patients with ME/CFS, but they don't meet the criteria for a diagnosis of anxiety and depression. So in clinic, I would make sure that any patient that I see, their sort of mental health has been looked at, if they've got severe anxiety or depression, that they've treated that first. They may be on medication, they may have had some psychological support so that their mood is stable to undergo therapy within our service.
So coming back to the specialist service and that relationship with the GP, are you sort of happy for us to do the tests in GP that we would normally do as a sort of tiredness screen and then pretty much diagnose chronic fatigue and refer on to the specialist service. What does that specialist service look like now, given that we seem to have some separate long COVID clinics that popped up? But if I've understood right, you've sort of said there's probably not a lot of difference between how you treat long COVID and ME, chronic fatigue.
So it's quite a difficult one, because in GP, and I work as a GP as well, is that you've got 10 minutes with a patient, and often, patients are diagnosed off a telephone call. It's quite hard to address all the symptoms in one go, but it's important, like I said, to exclude other conditions, and commonly find that conversations haven't been had about simple things that could help and contribute. So, looking at a patient's BMI, for example, have they got any cardiovascular symptoms, for example? Commonly, I see women in clinic who are assumed not to have cardiac disease. So they may have chest pain, palpitation, shortness of breath. That all needs to be addressed. It's important that a patient is examined at least once in the trajectory before they are referred. Another common thing I see is issues with periods, so having painful, heavy periods, and often you can have a normal hemoglobin but a low ferritin, and it can cause post-exertional malaise. So, addressing that, talking about iron supplementation, but also getting to the root cause of, the heavy bleeding, for example, maybe endometriosis or PCOS, which can be helped with lifestyle factors, but also with medical treatment as well. So addressing those things. And I often find as a GP, or even before I make a diagnosis of ME/CFS, I've initially assessed somebody, is that I give advice around that, and actually they get better even before making a diagnosis. So those are all important things to consider. I would check B12, folate, all the other conditions I mentioned, vitamin D levels, for example. And your question about long COVID, yes, I definitely would refer somebody, even if their symptoms started after COVID. I mean, there are some specialist centres for COVID that are still open, but some are closing down. I would say differentiating feature would be whether they've got a lot of physical symptoms. So if they've got a lot of cardiorespiratory symptoms, then that probably needs addressing first. So we don't have chest physiotherapy within ME/CFS services. That being said, if long COVID centres are closed in your regional area, then you can get community chest physio, for example. As long as that's being addressed at the same time as referring, that should be absolutely fine. And actually, there was a meta-analysis done of, I think, about 57 studies, and about 13 to about 43% of patients that had long COVID met the criteria for ME/CFS. And the prevalence of long COVID is much higher than ME/CFS. The management is the same, honestly, apart from maybe requiring support from cardiology with medication if there are orthostatic symptoms like heart rate going higher when standing up, or whether they need chest physiotherapy as well.
Is it fair to ask you, or it might be going off on too much of a tangent, about whether there's an overlap between chronic fatigue and fibromyalgia? Because when you were setting out the symptoms of chronic fatigue, a lot of those come under the definition of fibromyalgia as well, although, of course, there are other symptoms as well. So can you talk to us maybe about some of the similarities or differences between the two?
It can be quite difficult to get your head around. So there are massive similarities, and very similarly, there's no sort of blood test or biochemical marker for fibromyalgia either. And it's a condition that causes widespread chronic pain throughout the body. Initially, it used to be diagnosed by rheumatologists doing pressure points, so looking for points in the body after triggering and seeing if they are painful. That's gone. So we have a criteria set out by NICE called the Widespread Pain Index and Symptom Severity Score, and that makes up a fibromyalgia score. So you tend to have pain within the upper body, the lower body, and the back as well. And those sites of pain can flit from day to day, but you can also have symptoms of ME/CFS. So you can have the post-exertional malaise, you can have the brain fog, and both conditions can coexist. But we don't give both diagnoses. We don't say somebody has chronic fatigue syndrome and fibromyalgia. We go by what symptoms are the worst for the patient. So if the pain is worse or if the fatigue is worse, So you would say chronic fatigue syndrome with features of fibromyalgia, or fibromyalgia with features of chronic fatigue syndrome. It's kind of arbitrary because the treatment's the same. Again, it's self-management techniques. However, fibromyalgia is not a diagnosis of exclusion. So obviously you need to make sure that they haven't got a rheumatological condition that is explaining their pain. For example, if they've got rheumatoid arthritis, but they could have other conditions like, uncontrolled diabetes, for example, but also have ischemic heart disease and have fibromyalgia, whereas it's not the case for chronic fatigue syndrome. So I also look at that. It might be that the fatigue is worse, but they've got another condition to explain the fatigue, sleep apnea, whatever it is, but they've also got pain that meets the criteria for a fibromyalgia diagnosis. Then I would say it's fibromyalgia with features of chronic fatigue syndrome.
Got it. And just out of interest, if you had somebody referred to your service and the resulting kind of assessment was that this isn't chronic fatigue, it's more fibromyalgia, would you carry on seeing them, given that you've said that the treatment options are probably the same?
So I think you asked before what are the provisions for ME, CFS, and fibromyalgia. So it varies from every borough, every place, to be honest with you. So I used to work in Hertfordshire. I currently work in UCLH. And in Hertfordshire, we have a separate service for fibromyalgia and a separate service for ME, CFS. So I could diagnose fibromyalgia, but they'd have a slightly different pathway with the fibromyalgia. However, at UCLH, we treat both conditions, so it varies from place to place. And one area may not have a fibromyalgia service, but may have an ME/CFS service. So I know it's really difficult for patients. A good way of seeing what's available is going on the ME Association website, for example, and having a look at where the regional centres are, so you have an idea of where patients can be referred to. Some tertiary services like UCLH do take patients that are outside of London, but obviously there's the practicalities of traveling into London. I know that some of the therapies can be done remotely. I like to see a patient face to face just for the first appointment because, like I said, it's a diagnosis of exclusion. Hopefully the GP has done that, but maybe they haven't. And also to establish a rapport as well, to see the patient for the first time face to face. So it's very difficult because I can't tell you that, it's one way or another because it varies from place to place. And I can imagine that is very different in different countries too.
Yeah, of course. Yeah, that makes sense, Tila. But I suppose for any GP who's suspecting a CFS diagnosis and is making a referral once they find out who their regional centre is, what sort of lifestyle interventions can we be recommending while patients are waiting?
It's very different with what I would ideally want to recommend and what is being done. Okay. Because as I mentioned, there's not been much research in MECFS. A lot of the focus is on the psychosocial, it's on the movement and physiotherapy, as well as occupational therapy and pacing activities. But what often can be missing is a nutritional aspect. Some centres have a dietitian, but it's kind of the generic advice around what's in the Eat Well guide. There hasn't been any randomized controlled trials on MECFS. There have been individual studies looking at individual aspects. So it may be CBT, it might be, mindfulness, or it might be physiotherapy and graded exercise therapy. But there hasn't been a randomized controlled trial that looks at everything together, that as we do in lifestyle medicine, so looking at the 6 pillars: mental well-being, nutrition, exercise. So it's difficult to say that this myriad of therapies definitely works for chronic fatigue syndrome, because we're not there yet. We don't have all the information. What I like to say to patients, though, is that, look, every single chronic disease is based on inflammation, and there's no such thing as one lifestyle for one condition and one lifestyle for another condition, right? If you look at animals in the wild, they all follow the same lifestyle. They don't have different nuanced ones, right? We might be slightly more predisposed to certain conditions compared to other people, but there's the term epigenetics, where 90% of our genes can be switched on and off by a lifestyle. That's not to blame anyone. That's not to say this is your fault, but to look at it positively and think actually there's a way forward to getting better. And it might not impact your chronic fatigue syndrome fully, or your fibromyalgia fully. You might not get completely better from that, but it will help protect you against other diseases that impact your fatigue, because every single condition can cause fatigue. So I like to put it that way. There's nothing to lose by looking at lifestyle factors, and actually every single condition can be helped by it without any side effects, really, only good ones. I would say focus on your mindset and nutrition first. When we don't know enough about a condition, we just sort of assume that it's not going to get better. And I think patients are told that. And what do we do when we're told that, there's nothing you can do about it? Either someone, use that as a spur to say, no, I don't believe them, or you believe it and that doesn't get impacted. I refuse to believe that because there's not enough studies done. Like I said, that study that showed that there wasn't any structural abnormalities. Not to minimize the condition, not say that, people can't have persisting symptoms. But I think a belief that you can get better is really, really important. Having a more positive mindset. That's not, toxic positivity in terms of everything's great. I have a roof over my head, so I should be happy. But, often we overlook those small changes that are going in the right direction because they're often very subtle. So practicing gratitude and having the right mindset towards that and actually loving yourself. I know it sounds very woo woo, but if it was our child that was unwell, we'd do everything in our power to get our child better. We don't put ourselves in the forefront. So it's really important to use that time to invest in yourself. A lot of my patients kind of get stuck worrying about the outcome because they've tried so many things during their lives. And this is another thing to try that may not get them better. So I try to say, look, try and take the outcome away. Try to not think that if I do this for 3 weeks, will this help my fatigue or not? Use it as a baseline that this will help my overall health. Then I would focus on nutrition because, that's 90% of the the anti-inflammatory effects from food is really, really important. Every chronic disease is based in inflammation. So I would say start with mindset, start with nutrition, and then also make small changes with other things such as exercise. You may not be able to, leave the house. Being out in nature is really important. We get so much feedback from nature. And I try to say, look, again, this is not woo woo, there's a scientific basis around it, right? Trees produce phytonicides, which are chemicals that our body absorbs, our skin absorbs. And that increases natural killer cells in our body, which fight inflammation. Our circadian rhythm is affected by light. So, having a bit of light in the day, although, UK weather, but still having that bit of nature really helps. Even if it's 5 minutes, it might be you can't get out of your door. You might be living on the second floor flat with stairs and you can't get out. But opening that window, looking outside, or creating, a small area of nature within your house. It might be a table with a nice plant that you've got there that you can focus on, or doing some grounding exercises, it may be at home. All of those things can help. I really strongly believe in seeing where someone's at. A lot of my patients focus on what's the ideal. So the ideal is having, kale and butternut squash salads. Everything's organic and going and doing yoga for 5 hours. Most of us can't do that. For most of us, it's a gradual change. So looking at it as a stepwise approach is really, really important, and trying to take the outcome away, because a lot of the time someone sort of not within that circle can see the changes, but they will come gradually. And I think it's important to believe they will come.
For people that perhaps new to lifestyle medicine or nutrition that are coming to this podcast for the first time, having seen that we're doing an episode on chronic fatigue syndrome, what sorts of nutrition advice would you give, like you mentioned, for general health that helps all chronic conditions, inflammatory conditions? What sort of plant-based foods would you be recommending?
So I always recommend a variety and looking at your overall as opposed to looking at individual, superfoods, because, I see lots of patients on lots of different vitamins and minerals, which may be interacting with each other or their medication, or may not be doing very much. And it can get quite sort of disabling having this routine with 15 different medications. So I try to look at it from an abundance point of view. And if you're just having toast with butter in the morning, for example, what can you add to that to add more antioxidants? So I'd put some avocado on there, I'll put some tomatoes on there, some spices, all of that kind of stuff. So focusing on abundance. A lot of my patients have restrictive food patterns, so they may have functional gut disorder and not being able to eat things like legumes, for example. So I always advise with starting with what can you eat? Do you like grapes? You can eat grapes, add more grapes. Why aren't you including that in your porridge? Often, someone will say, I just have porridge in the morning, and I elaborate what's in the porridge, and they just haven't thought about it. They're just like, oh yeah, just milk. So yes, add some seeds in there, add some seeds for the omega, and that fights inflammation. Put some berries in there, which have anthocyanins, which fight inflammation too. So it's about abundance as opposed to restriction. But also, I don't think we should have completely set rules. So they don't have to be vegan in order to have the benefits from plant-based nutrition. Focus on abundance. Try to take the all or nothing mindset out as well. I do think, if there's specific issues like, having a low iron, it may sometimes be hard to catch up with diet alone. You have to look at the root cause if there's heavy, period disorders, for example. But the root cause of a condition like polycystic ovarian syndrome, for example, can be helped by having a more whole food plant-based diet in the first place. So somebody who's got heavy periods, I would focus on iron-rich foods in the plant kingdom, because we know that non-heme iron from plant sources is better for us. It has less of the risks of the animal products that contain heme iron. So, adding in things like green leafy vegetables, beans, lentils, chickpeas, and adding a vitamin C source, like just squeezing lime over your food, for example, or having strawberries for dessert afterwards, can be beneficial as well. So there's individual approaches to different circumstances.
I always worry about some patients who have spent so much money on supplements unnecessarily. Is there really any evidence for any particular supplement in CFS, or should we be discouraging that?
Honestly, I think we should be discouraging that, because, I see so many patients that are on lots of different supplements. Some are, they're not harmful, I would say. Some could have interactions with the medications that you are on, but it can lead to this kind of hypervigilance and worry about needing to take all of these things to get better. And I forgot to take this, therefore I'm not feeling well. Honestly speaking, I don't think there are any super supplements for ME/CFS, and unfortunately, it's very unregulated in the private sector. There's lots of, private specialists giving a high dose B12 injections, for example, plasma exchanges. This is a vulnerable group of patients. Maybe the treatments are well intentioned, but they're not evidence-based in terms of working. I would probably advise, at the bare minimum, if somebody is plant-based, to be on a B12 supplement of 50 micrograms a day, or 1,000 micrograms twice weekly, or, certain circumstances where, they're above the age of 50, they've got low levels because they're not absorbing well, they're on certain medications. Iron, if they've got low dietary iron and at the moment their diet is not optimal, or if they've got a reason for blood loss, for example, having heavy periods, I would recommend iron supplements. Everybody should be on a vitamin D supplement, regardless of, the summer here, to be honest with you. So 10 micrograms a day. But other than that, I don't really recommend supplements. People may choose to take an omega-3 supplement. I know you've got an episode on omega-3, so I won't talk so much about that. And possibly iodine. We don't have an easy way of getting iodine in our diet. So anyone that's an omnivore and consumes dairy, they do get iodine in their diet because cows are disinfected with iodine. However, if you're on a plant-based diet, it may be harder to get iodine. It is in sea vegetables, so having about 2 to 3 sheets of nori a day could be helpful. But, how much you absorb can be variable, and we don't iodize our salt in the UK. So taking a 140 to 150 microgram supplement can be useful, but some plant milks are fortified with iodine. You can also take a multivitamin which has iodine as well. But those are probably like a handful of supplements I would recommend. But other than that, there's no evidence that there's any particular supplements that help with ME/CFS or fibromyalgia.
What about things like apps? I mean, patients have mentioned that they might be tracking their heart rate to manage their stress, or is there any particular gadgets or gizmos you'd recommend for your patients?
Again, sometimes this can do a lot more harm than good, especially if someone's, obsessing over their heart rate. The new thing is glucose monitors as well, and looking at sugar spikes after eating, which is a perfectly normal phenomenon. I mean, there are some apps that can be helpful. A lot of my patients with long COVID or ME/CFS use the Visible app. A lot of the apps are made by people who have had ME/CFS themselves, and obviously because there is wide variability in terms of service provisions, I think a lot of individuals have taken it upon themselves to make these apps and gadgets to try and help. So I think they're well intentioned, but unfortunately the market is such that, there's a lot of kind of unregulated things which could be more harmful.
Yeah, you don't want people to start stressing more about monitoring various parameters, I suppose. Yeah, makes sense. And what about the graded exercise therapy that you mentioned? I heard you saying somewhere that this has been removed from guidance, because I often do try to encourage CFS patients to do some form of movement or activity where they're able to. Is that something we should or shouldn't be really recommending in general practice?
So, yes and no. So, the context around graded exercise therapy is that there have been quite a few randomized controlled trials that have shown graded exercise therapy to be useful in ME/CFS. And particularly in 2011, there was a study done comparing graded exercise therapy with CBT compared to pacing activities. And they felt that the graded exercise therapy with the CBT was more helpful in terms of symptoms. However, that study was criticized in terms of its methodology, but also a lot of individual patients have found that it actually exacerbates their symptoms because you've got this issue with energy management. You can have these booms where you've got lots of energy and you can do lots of activity, but then you have a crash. The graded exercise therapy was thought to be very kind of generic in terms of, not taking an individualized approach as to how an individual in their circumstances should improve their activity. So NICE guidance has removed graded exercise therapy. It should only be used in specialist centres. So, if you are under a service for ME/CFS and you had mild to moderate ME/CFS, but that's kind of obvious in terms of if you had severe ME/CFS, you wouldn't do graded exercise therapy. But I think, you can encourage physical activity in a stepwise fashion within the service I work in. We do have a physiotherapist who will take an individualized approach as to activity. So exercise is good, but there's some nuances in terms of graded exercise therapy.
Okay, that's really useful to know. Thank you. And I suppose overall, looking at prognosis, is CFS a long-term thing or do people get better? I mean, have you got any success stories from patients at your clinic?
So again, it's quite difficult because, as I mentioned, there's not any studies in terms of prognosis of ME/CFS. We don't know what the cause is as well. And there hasn't been a randomized controlled trial. I would love there to be. I would love someone to pick that up and do that. There is a large biobank study going on over 8 years. The results haven't been published yet. That will give us some more information. The types of therapy differ amongst places as well. So I don't know how much that will reflect, if we did the optimal in terms of therapy, what would the outcomes be? We do know that outcomes are better in younger people with ME/CFS, so adolescents and children. However, as I mentioned, there's no objective evidence of structural damage, as I mentioned, and I am following up patients that are getting better. I can't promise a recovery for anybody, whatever the condition they have. So I like to put it in that manner that, we're not, aiming for a cure for ME/CFS, and there is some acceptance around, this is what I can do now. This is my situation now, right? I know that people can mourn the person they used to be, and that's really important. But moving forward and thinking, actually, what does well now or in the future look to me? We often share a video by a psychologist called Tamar Pincus called My Pain and Me, which is really useful. And it's about her having this plasticine of feeling, negative in terms of, what is my condition now is limiting me with all of these things. But then adding in all these new things, my life looks a lot different now, but it's better and brighter. I would say that patients do get better on the whole. How much they get better, the prognosis is variable. There are, patient stories of people that have, completely got better from ME/CFS. For example, there's a channel by someone called Raylene Agel who actually follows a more kind of whole food, plant-based lifestyle, has quoted Dr. Dean Ornish, for example. Doesn't necessarily need to be plant-based, but I think a lot of the similarities in her channel are that a lot of people have, tried all these different supplements, different treatments, as I mentioned before, and they've not helped. and then gone back to basics in terms of looking at nutrition, looking at mindset, looking at pacing activities, and gradually challenging that. So that's all useful. And I would say, in terms of my patient stories, I can give you two examples. I've got a male patient with ME/CFS who had very severe headaches. He wasn't able to get out of bed basically with his headaches. He was housebound. He saw me after one appointment. He just decided, look, I'm going to go and do this. The next time I spoke to him 6 months later, he was like, I'm more than 90% better from my headaches. I'm having social activities now. I just followed every recipe on your website. So I'm feeling a lot better. Thank you. And then he was like, well, shall I just come off on all of my blood pressure medication now? I was like, no. You need to assess the situation with your GP. But that was quite a nice and positive story. And I do have, quite a few situations of young women with ME/CFS symptoms, but also cyclical symptoms, heavy periods. I support that, but also, we refer to occupational therapy. They look at their nutrition, and the symptoms are a lot better. The post-exertional malaise is a lot better. They're able to go to the gym. Their life's a lot better. I wouldn't say, 100% cured, but they can live life as they want to again.
Yeah, it sort of makes sense intuitively, doesn't it? I mean, you sort of hear a lot of people who go plant-based and they immediately say, oh, I've got so much more energy. I feel better. I feel, good in myself. There's something quite healthful, isn't it, about eating fruits and vegetables and whole grains and legumes. And hopefully, I hope your patients will also experience a bit of that.
Everybody reports some positive outcomes as long as they do something to change things positively. So I kind of say, the only person that will hold you back from getting even a bit better is yourself, and believing that you can get better from doing this.
So I'm going to segue across to your social media presence now, Tila, and you're one of these great doctors out there that are attempting to deal with the tidal wave of misinformation. And one thing you do in particular is something called Myth Busting Mondays, which we love. There you're posting little videos which comment on common health myths. What's been your favourite one to do there?
What spurred it on was I get frustrated hearing the same things over and over again, and the common myths. I think one that I commonly hear is about gout, and it's about, having this predisposition to gout, and it's just about stopping red meat and alcohol, and those are the trigger foods. But actually realizing that the prevalence is higher depending on your overall dietary pattern. So, you might not even be eating red meat. It might be that you have, high animal foods in your diet, but not a lot of plant foods. So that was a really, really good one to dispel, really. And I always go back to my video on that.
Outside of your NHS work, are you also working as a health coach at the moment, as a lifestyle medicine coach?
Yes, I do. And I've had some positive outcomes from that too. So I do individual coaching. So I do hour-long consultations with clients with just lifestyle coaching. I like to give them the evidence base for things in a way that they can understand and take away, because I think it's really important to have a why and to understand why you're doing it, rather than say, do this, this, and this, because it's less likely to stick. But I found that even a 90-minute consultation, so an hour and a half and nothing else, is really, beneficial for people to have positive outcomes. And I'll give you an example of someone recently who had, cholesterol that was significantly high and fatty liver disease, and was told that, look, we're really close to putting you on statins. And he was like, well, I really don't want this. He had heard about plant-based eating, but his family was kind of reluctant to do it, and he was thinking, how am I going to do this? Really, it's a completely different way of learning how to cook, and he's not, a Michelin star chef. He's used to basic recipes. He works quite long hours and needs to have things that are quick. So we took a very sort of stepwise approach, looking at, actually, your lunch is this at work. How can you get all of those things into your busy lifestyle? And actually, within about 2 months, his cholesterol has come down to below the cutoff. So it's below 5. He's lost loads of weight as well. He's got a lot more energy. And he thought, look, I'm only going to do this for 3 months and then maybe just see where I can include all the animal foods to a small extent as well. But he's enjoying it so much that he's like, well, I think I'm going to continue.
That's a lovely story. I think it's so fantastic when people say, I could never do this plant-based diet. And then once they try it, and they realise actually it's about eating more things that they'd never thought of. And you get these really beautiful stories about patients switching over. One of the things that we try and do on this podcast is we do like to lead by example, don't we? So this is the point where if any of your patients are listening or any of your future patients, they're going to be really interested in what you're having for dinner. So can you tell us?
So we have this every week or every fortnight, and if it was up to my daughter, she'd have this every day. So I'm making sloppy joes. Well, I started to make it. So we make it out of TVP and mushrooms, and I add peppers in there as well and onions. And it's a really easy recipe because it's one pot, and you just bung a load of things in like nutritional yeast, Marmite, and tomato paste. So it's kind of like a very kind of meaty, hearty meal. And my kids will have that in buns with a little bit of smashed avocado, and then we'll pimp it up with jalapenos as well. And then I like making a side salad. So we're having a Thousand Island dressing, which is really, really easy to make, which is literally just plant-based yogurt, some ketchup, some garlic powder, onion powder, and some chopped up gherkins. And there we've got like a salad and sloppy joes, and we're not going out to a restaurant, but it feels like we are.
I don't think I ever knew what sloppy joes were. So thanks for clarifying that.
What,
it's the sort
until
of thing,
now?
Not
Claire?
until now. It's the sort of thing that you used to read in a Judy Blume novel
That's so
that they were
funny. I
having
guess
sloppy joes.
it's American, isn't it? Sloppy joes?
Exactly.
Yeah.
So I've made it for a few people in the UK, and they're like, "Oh, I never knew what that was." And
Me neither.
it's literally just mince, but it's kind of supposed to be sloppier, so it's supposed to be a bit more runny than just making a bolognese, for example.
I'm so glad it's a plant-based version. The mince, the beef mince one sounds absolutely horrible. Daisy, what about you? What's happening in your kitchen tonight?
So we're also having a plant-based mince replacement. So we're having a spaghetti bolognese, but my husband makes a really good version actually. So I'm leaving it up to him. He does a mix of plant-based meat replacement and lentils, because if it was up to me, I'd just do lentils. I'm quite happy with that. But he still likes that mouthfeel of what he used to eat, I suppose, before we went vegan 5 or 6 years ago. So he does a combination. We've sort of agreed that he'd do half and half. So it's half lentil, half, I think he uses like Meatless Farm or something like that, like a plant-based mince.
My husband's exactly the same. He'll ask permission. He'll be like, "Well, can I just add a plant-based meat to this?" Because he likes the mouthfeel as well. So if I left it up to him, he'd do the same.
Try the half and half. We're all happy.
Yeah, I will do.
What about you, Claire?
Well, no one's cooking for me tonight. I'm home alone. So I thought I would make myself something that I don't make very often. And I'm actually probably going to have to refer back to the recipe. I'm going to make a tofu omelette. So it's an omelette that's with silken tofu, nutritional yeast, some of the calamata, the sulfur salt to make something more eggy. Kalanamak, that's the one. And also some gram flour, the chickpea flour, to bind it all together. And then you can put what you want in it while it's cooking. So you just make it like you would an egg omelette, I guess. But you fold it over, and I'll put in some spinach. And I don't know, I think I've got some actual pre-made vegan cheese that I'll put in there as well.
So like a proper omelette. Very nice. I've not tried that vegan style yet. I should do, shouldn't I? Seen that a few times.
I'll make it for you, Daisy.
Oh, thank you, Claire.
As well.
Yes. Come on, you'd be absolutely shocked if I had you round for dinner and I was like, it's an omelette.
Yeah. Like, come on, Claire, do better than that. Claire's normally the one with all these intricate, amazing sauces and recipes and things.
Well, I like to cook for people. So if I'm cooking for myself, I'm literally just thinking, what 3 things can I open and make some kind of meal out of it? And that's what's happening tonight.
Quick and easy. We like that as well. Well, listen, Tila, it's been really great chatting with you. We've really enjoyed having you on the podcast. And thank you for your time and your expertise. And I'm sure our listeners will get a lot out of this episode. So thank you once again.
Thank you.
And if people want to connect with you and find you, will you let us know how they can do that?
Yep, so I've got a website. It's I'm known on social media as the Plant Promoting Doctor, plantpromotingdoctor.com. I've got lots of free recipes on there. I write a blog on there as well, and you can find out about my coaching services from there. Get a 15-minute free discovery call. But I'm also on Instagram. I haven't been on there quite so often lately, but it's the same name, Plant Promoting Doctor, with underscores between each word.
Wonderful. We'll put all the links in the show notes.
Thank you.
Thank you.